Now for introductions, I'm pleased to introduce our three presenters from the Pan American Health Organization and the World Health Organization, Doctors Daniel Buss, Jonathan Drury, and Joseph Spadaro. Their presentation is entitled International Collaboration for Achieving Health Co-Benefits through Innovative Climate Action. Dr. Daniel Buss is an advisor on climate change and health and coordinates PAHO's technical cooperation to 35 countries and 18 territories of the Americas on topics related to climate change, green spaces, biodiversity, public health, and environmental health. Dr. Jonathan Drury is a regional climate change and health advisor and provides technical cooperation to address the environmental determinants of health. He also supports the implementation of the EU CARIFORUM project to strengthen climate resilient health systems in the Caribbean. He has worked in public health leadership, programming, and training for more than 25 years and throughout the Americas. Dr. Joseph Spadaro is an environmental research scientist and is presently an expert consultant and software developer of integrated health and economic impact assessment models for research use as well as policy analysis. He developed methods and software tools to assess the health co-benefits of climate mitigation interventions. He has worked in the US and in Europe and for the International Atomic Energy Agency in Vienna. He's co-author of several books and major technical works. So welcome to the team from PAHO and the WHO. Welcome. Dr. Buss?
Thank you. Thank you very much. Good morning to all. Good morning, Dr. Richards. Good morning, Satesh. It's a pleasure to be with you all again. I see many known names in the audience, which is great colleagues, friends. Let me just share my screen so I can jump in my presentation. The idea, yeah, I hope you can see it now. So the idea is to discuss, as presented, some of the international collaborations and opportunities that we have and that we perceive as Pan American Health Organization and the World Health Organization. The Pan American Health Organization, or PAHO, is the regional office for the World Health Organization in the Americas. We are based in Washington, but we have offices in the 3 subregions of the Americas and in all country offices in all countries of the Americas. Part of the presentation that I had prepared for you today is on the topic of climate change and health and how international response is being built around it. Just a quick overview. I was hearing the previous presentations, which were super interesting. I really look forward to be able to engage with them. Many of the topics are the same topics that we are working in this agenda. And climate change, as you can see in this image, can have direct impacts to human health through extreme weather events, heat waves, wildfires, disasters, also impacting natural systems such as air pollution and increasing food and water contamination, and changing the distributional patterns and behavior of vectors, hosts, and pathogens, but also through socioeconomic systems as increasing food and water insecurity, causing conflicts due to resource scarcity, producing forced displacements and creating mental disorders. Of course, that we can go in detail to each one of those, and we have a couple of, well, several publications that we build those linkages. But health as a sector and the society can have two kind of filters to reduce health impacts. One is through social and behavioral contexts. So working with education, especially now in times of COVID and pandemics, I was hearing other colleagues mentioning this, the importance of, wearing all the protection and prevention equipments that you can, masks, social distancing, etc. And but also we can work in improving health systems conditions, which are crucial to be able to deliver primary healthcare and also having health infrastructure in place during and soon after extreme weather events, for example, or when needed. And those filters can help. And those two filters would be part of the response of health systems as part of the adaptation to climate change to reduce health impacts. But you can also work cutting those lines on top of this figure by doing mitigation activities to reduce the impacts of climate change on those components. Well, the region of the Americas is a very complex region. As you know, we have North America with one kind of condition, I would say, social and economic, then Central America, including Mexico, Latin America, or South America, also with particular conditions, and the Caribbean. We work with all those countries, providing collaboration and technical support through our offices, as I mentioned. And there's a wide range of impacts as heat waves and wildfires, droughts, water and food insecurity, landslides, altered patterns of precipitation, hurricanes and storm surges, vector-borne diseases, air pollution aspects, sea level rise, and I'll fly by some of those as I go through my presentation. But now focusing on a little bit of how we respond to that as PAHO WHO and building this international collaboration to respond to it, we can certainly organize this the response in major topics, which would be one of them, improving health system surveillance and healthcare services through planning, helping countries to have better plans, better national adaptation plans, nationally determined contributions, vulnerability and adaptation assessments on health, about the effects of climate change, building observatories on climate and health, which will always also be crucial for example, for anticipating new epidemics, new pandemics. So it will also help us to reduce the risks or anticipate some of the risks associated with new diseases or discovered diseases, such as COVID. Increasing capacity building for health professionals, building early warning systems for extreme weather events, heat waves, vector-borne diseases, outbreaks, and others. And we have an interesting project that I'm going to mention to you briefly called Country Profiles on Climate and Health, where we just 2 days ago, we launched 6 Caribbean countries profiles, including Grenada's, which I think you might find really interesting. And we have a component of enhancing health infrastructure, also increasing climate finance, and working with at the city level, not only at the sub-regional level or regional level or country level, but also at city level or subnational levels to measure health co-benefits from intersectoral interventions, from infrastructure interventions as well in cities. So about the VNAs, vulnerability and adaptation assessments and national adaptation plans and nationally determined contributions, we have a number of publications on that, on guidelines to help countries on how to do that. And we have been working with them closely to help countries preparing those documents in the corresponding health part. We also, as I mentioned, have recently published, in this with a major effort with ministers of health and ministers of climate change or environment from the Caribbean region, the Caribbean Action Plan on Health and Climate Change, So I invite you all to take a look at that. It's major commitments, major mandates of countries and PAHO and WHO to respond to some of the demands and some of the problems that that countries of the Caribbean are facing now with regards to climate change. And we have been doing the same in other regions of the world, like the Andean region, like Mercosur in the southern cone of South America, and also in Central America. So this is kind of a family of products that we do in conjunction with other countries. So to build together not only national activities, but also how to build consensus at the subnational, sub-regional level, and so countries start to collaborate with each other and create common indicators and common activities to jointly address climate change related topics. So about the country profiles, this is now at the more national level. So so we had recently published, as I mentioned 2 days ago, so I'm presenting that firsthand to you, a number of Caribbean country profiles, and going to just to flying by through the Grenada's. And again, I invite you all to take a closer look to that. So the climate hazard projections for Grenada and how that translates into health indicators, for example, on NDCs, how is the situation and what we can extract from the climate projections, future risks. Also, a little bit on what are the current adaptive capacities in the countries, right, to respond to the new threats or to the enhanced threats caused by climate change. So we have to understand where we are now with regards to capacity to respond, and climate change will exacerbate some of those risks. So that's why it's important for us to understand where we are in each country to better prepare strategies to respond. Of course, everything that I'm presenting here was produced with Minister of Health and other ministries in each country. And also we have a part on how the health sector in each country, how they are responding to climate change. So what are the institutional capacities, governance capacities, what are the legislation that is valid in each country, and to provide support. And this is a pretty kind of an overview on how the country is with regards to this topic and response. And also 2 days ago, at the same day, we also launched this very interesting publication, which I really invite you to all to take a look at. It's a pocket book for climate change for health professionals. So I was hearing the previous presentations when they were showing the connections or causal links between climate events and pathophysiology effects. And we did that through review of literature with many colleagues from this region and elsewhere. And we provide some guidance and information for health professionals to have that at hand as a pocketbook, depending on their specialty. So for example, cardiovascular diseases, respiratory diseases, gastrointestinal diseases, eye diseases, vector-borne and zoonotic, skin diseases, maternal and pediatric disorders, neurological, kidney disease, and mental health disorders. So we have that all mapped out, and with the most up-to-date information on what are the linkages between climate and health in each of those medical specialties, and also, for example, which medications not to prescribe during floodings or during a heat wave, because it can exacerbate some effects of climate change. We are working with many countries on developing observatories on climate and health, so we can collect information of environment information systems, health information systems, climate information systems, and social demographic information, and putting that together in a way that those indicators can talk, and then we can project some of the trajectories of diseases and ideally anticipate and prevent some diseases to spread, or even create some response and quickly recovery mechanisms for heat waves, as I mentioned, acute respiratory diseases and others. And as I mentioned, another topic would be on health infrastructure and services. PAHO has a recognized, world recognized project called Smart Hospitals to work on health infrastructure. There's plenty publications about that as well. It's meant to increase safety, make sure that healthcare facilities can operate during and soon after any event, and also increasing the green part of the hospital, so reducing greenhouse gas emissions, reducing wastes and energy consumption, for example, and water consumption. So those are some elements that we work that are in between the mitigation and adaptation response. And just to introduce us to the next colleagues that are going to speak, this is one of the works that we have called Breathe Life Campaign, where WHO, PAHO, we aim to reduce air quality, improve air quality or reduce air pollution in cities. We have a number of tools that are meant to also help countries to estimate the health co-benefits of improvements of air quality. We have one tool called Air Quality Plus. We have one that aims to measure the health co-benefits of interventions on green spaces in cities, and also one related to measuring the NDCs, or nationally determined contributions, how at the national or city level, improvements in reducing carbon emissions and also reducing short-lived climate pollutants, how that could translate into health co-benefits. And we have a presentation today for you about that. But before that, I would like to introduce Dr. Jonathan Drury, who is our colleague from PAHO Barbados, and who is managing a project that we are conducting with many partners to specifically in the Caribbean region. I can't really see him, but Jonathan, are you?
Yes.
Yeah, great.
Thank you for the introduction.
Thank you very much. I'll stop sharing my screen now.
Hi, can everyone see my screen?
Yes.
Very good. Well, thank you for the opportunity to present today. My presentation is really focusing on this EU Cariform project that Daniel mentioned. And the main focus of my presentation will really be on an overview of it and some of the details for year one in terms of activities for the sake of time. But we will have a Q&A, so I welcome any questions. This project is funded by the European Union, and it was really conceived a number of years ago, the idea to really bring together a lot of both CARICOM and other organizations in the Caribbean towards a common goal, a common vision of working together on climate and health. And so it engages many different partners. SGU is one of them. It also engages 16 countries, 16 Cariform countries. And so it's part of a multi-sectoral interdisciplinary collaboration towards developing regional public goods, but also working at the national levels. So here you can see from this slide at the bottom, some of the main partners that are working with us. There are also others. Some important ones are the universities like SGU. So really one output here is looking at, Daniel mentioned Dr. Bush mentioned the HNAPs. And so the Health National Adaptation Plans, in other words, working with countries to see what are the gaps that exist in terms of them looking at qualitative and quantitative data linking health and climate, but also prioritizing what they really would like to do, and then the next step of having resources in order to do that. Another are the tools to look at co-benefits that Dr. Bush mentioned too. That is something we'd like to pilot in the Caribbean, health impact assessment, and particularly some of those tools that Dr. Bush just mentioned. The third, really promote awareness about climate change and health in the Caribbean, so that everyone is aware of what's the interplay between climate and health, how does it affect them, targeting different populations like youth and the general public and the health authority. Also, early warning systems and select environmental determinants of health to see how do we make linkages in the country between health data and climate data, and how do we use that to forecast and predict and influence different sectors. And then leadership is key to all of this. Without having the human capacity to do this work, we wouldn't get very far. So that's another important piece through a fellows program and through youth. So I won't spend too long on this slide. It's some of the activities we have for year one, but the main points from this are to see that we're in the beginning phase. This project is 5 years. It started in July with a small inception event and runs through 2024. So as I said, we're right now at the planning, inception, and awareness phase. We've finalized the partner work plans, established governance, advisory groups, and conducting assessments for climate change and health, and developing some communication and visibility materials. So impact assessment and WHO PAHO tools. This is going to be led really by PAHO, but also with a number of other partners. So for year one, we're really looking at mainly training in health impact assessment tools. So some of those things that Dr. Boos mentioned in terms of looking at how active transportation, air quality, how do all those things influence health? What are the economic benefits of health? And then demonstration countries. So we can work with a number of countries to really pilot those and then support them along the way with resources and technical assistance, and engage some of the universities in the region. Health National Adaptation Plans, PAHO is leading that with 5 Cs, and SGU is also supporting with that. Year one, we'd like to select and support some demonstration countries for a first phase. We're in that process right now. Then in December, we'll have a workshop to share opportunities, understand what are the key criteria to work through the HNAP. That'll be December 2nd and 3rd. And then next year, we'll select and support another phase of demonstration countries. Early warning systems in the Caribbean is being led by CARFA and CIMH. As you know, CIMH does the Caribbean Health Climatic Bulletin, and CARFA has been involved in developing integrated early warning systems. So in year one, they'll do baseline assessments of countries in the CARIFORUM countries, assessment and feasibility studies in 3 selected countries to serve as pilots. And then the workforce, the environmental health workforce in particular, and improving climate sensitive health outcomes. Really, by that I mean that we really want to work with environmental health providers and workforce and others to see how we can support them to address some of the issues and get involved in some of the climate and health projects at the national level. But it's also to look at what which of the environmental determinants of health are really influenced by climate. So to focus on a few with food, water, and sanitation. So in year one, it would be a baseline assessment of where countries are with some of their water and sanitation capacities and readiness to take on climate resilient water and sanitation safety plans. Select pilot countries, work with CARFA to develop trainings related to flood, food, water sampling. There are a number of manuals that have been around for decades that would need to be updated with sort of a climate resilient lens. And then from the food perspective, assess some of the issues with emerging food safety as it relates to climate, and update some of the manuals related to surveillance. And then public health performance, which is something that's been going on for a long time in the Caribbean and elsewhere in the Americas, but really engage further environmental health and see what are some of the gaps that they may have in addressing climate and health, and trying to mobilize resources and the Caribbean community towards supporting them. Leadership is key, having an institute really to focus on leadership and climate is an important part of this project. UWI, University of West Indies, is leading this, building on their successful One Health, One Caribbean, One Love project. With that, in year one, they'll develop curriculum, recruit fellows from some of the countries, and provide a training. There'll be 3 cohorts over the 5 years of this project. And the hope is to have an interdisciplinary group of fellows from the Caribbean trained in climate and health through a One Health lens. Also, with CARICOM is leading the way with this interagency youth leadership, and PAHO too is supporting them to bring together many of the organizations that have worked successfully with youth on climate and health together, so that we can continue to support youth leaders as advocates and engage them in events and engage them in projects at the country level. And then also events and training for youth leaders. CARICOM will be supporting that, making sure that youth and high-level officials from the Ministry of Health are at the table at sub-regional, regional, and global events related to climate and health. And then finally, the last slide here, which is by no means the least important one, is the Communication and Visibility Plan, which in part is to promote the EU as funding this, but also to get the word out even further. And I know climate and health has been a topic for PAHO and others for 20 years, but there's still a lot more to do in the Caribbean in terms of communicating to the public what this really means to them. So we will have a project launch on December 1st from 4 to 5:15, which you'd all be invited to. It will be live and sort of a high-level event to kick off this project. We're also conducting a climate and health perception survey in 10 countries to get a better idea of what the public really understands when we talk about climate and health, and what they think are the health outcomes that are most influenced. Where do they get their information? And at the national level, what do they know? And where do they get that information from in terms of things that are going on at ministries and other sectors? Also developing media, jingles, PSAs, videos, determining who are the influencers of climate and health, or could be the influencers of climate and health in the Caribbean, and focusing on them to get the word out. Also the training of journalists so that they can better report on health and climate, and promotional materials about the project for distribution on our website and during events. So I know that was a quick overview, but for the sake of time, I really just wanted to hit some key activities that we were engaging and starting with this new project. So with that, I thank you all for the opportunity to present and for your time. And I'll now turn it over to Dr. Joe Spadero, who's going to talk a little bit about a decision-making tool looking at health and economic co-benefits. So over to you, Dr. Spadero.
Joe? I can't hear you.
Let me request an unmute on Dr. Spadero.
Can you hear
There
me?
he goes. There you are, yes.
Thank you.
I'm hitting too many buttons.
We can see your presentation too.
Yes, trying to, there we go. Well, thank you so much for having me today. I would like to complement what has been already spoken to talk about a tool that I've been developing for the WHO called Carbon H, which is an acronym that stands for Carbon Reduction Benefits on Health. And using this model to make some predictions of the health benefits that one might achieve. Just to get the discussion started, I just wanted to give you a quick synopsis of the mortality burden and loss of life expectancy for and loss of, there we go, and loss of life expectancy for the Pan American area. On the left-hand side, you see the mortality as a distribution across the different countries expressed in per 100,000 population. And on the right, you see the loss of life expectancy for the different countries. And I've highlighted the case of Grenada, which accounts for about 80 deaths per year as a result of exposure to ambient air pollution. And that is a reduction in life expectancy of approximately 10 months. That is life expectancy at birth. And when you take into account the whole region, there's about 300,000 premature deaths. The average loss of life expectancy is about 7 months. This is at birth. And the disability adjusted life years are around 5 million. In terms of costs, because I also look at the monetization of these events, that ranges between $300 and $650 billion. These are in 2017 dollars. And this is a recurring cost year after year at current levels. And to put that figure into perspective, that represents between 1 and 2.5% of GDP. One of the previous speakers was mentioning that they had done a campaign on measurements of pollution. So I actually did a very quick calculation based on those numbers, and I would predict somewhere between 50 and 100 excess deaths in Grenada as a result of those numbers that were presented. So what's the motivation of developing this tool? The motivation is that we recognize that if we reduce carbon emissions, we also have the additional reduction of other pollutants. These could be, as indicated in the slide, sulfur dioxide. And there is a relationship between the two pollutants. That relationship is more linear for some pollutants, less linear for others. It also depends on the emission source that is being targeted. So the idea is to utilize this information and to calculate the changes in air quality and therefore calculate the benefits to health. And these benefits to health can be thought of as benefits due to mortality, number of cases, people dying, as well as changes in lifetime expectancy, which I showed on the previous slide. And these then are monetized, and these costs take into account not only market indicators, but as well as welfare gains due to quality of life gains in the population that is exposed. So climate policies really deliver a win-win outcome. They essentially, on the one end, address the issue of climate change, which Dr. Buss had mentioned before, and all the different interventions and programs that are being set up. But at the same time, these deliver health gains. And these health gains deliver for the population an increase in their wealth, in their well-being and healthy lifestyles. So Carbon H, as I said, is a tool for calculating the co-benefits to health from reduction of carbon emissions. So the benefit to health as a result of a transition to a low carbon economy. It's a decision support tool used by government planners or decision makers at all different levels of society, whether it's at a national level, whether it's at a subnational level, let's say local, or let's say in a grandiose plan at the regional level in an area. And it's a participatory process where different people are involved in planning, preparing, setting up these national or regional action plans. The stakeholders, the beneficiaries, of course, are the populations that are being exposed, both at the national and regional level. The time horizon is 2030, which coincides with the first reporting period of the nationally determined contributions. And there is a current version of the tool that has already been implemented in Europe. And it is presently in the form of an Excel spreadsheet, but an intelligent user interface is being developed. There are different versions of the model that will be developed to cover other regions of the WHO areas, as well as a global version. So what kind of information do we need to run the model? Well, it depends on the type of analysis that we would like to carry. If we want to do a basic type of analysis, then the only information that the model requires from the user is a set of reduction of pollutants. These reduction of pollutants are related to the different national action plans or regional plans that are being investigated. And it may include, for instance, particulate matter, SO2, NOx, and ammonia, any combination of these or all of them. And it may involve a single country or a group of countries. So in the example that I show in the slide, we have the European Union 28, which today is EU 27 plus Great Britain. And if in 2030, the collection of these countries were to achieve the targeted of 40% reduction in greenhouse gases, we would also have reductions on the order of 300 kilotons of PM 2.5, another 1,000 almost kilotons for both SO2 and NOx. So the benefits to health are through the reduction of these co-pollutant movements, and that's what Carbon H does. This is the only information that is required, but of course the model needs more information to carry out its actions. For that, it needs default data, and that default data is provided to the program in the form of lookup tables. These may be data on demographics, it may be data on health statistics, epidemiological functions, as well as costs per case of illness and other variables such as the value of statistical life, the VSL, or the value of statistical life year, which are values that are used to monetize mortality and losses in life expectancy. These data are modifiable by the user, that they could augment these data or replace them with local information. So what does the model give us? The model gives us three pieces of information. First of all, it tells us what are the changes in the PM 2.5 concentrations. These are calculated internally in the model using what I call source receptor matrices. These are correlations that relate the change in pollution in a point in space due to a change in emission somewhere else. They take into account not only the influence on the country itself that is no longer emitting that pollutant, as well as the influence of transboundary pollution from pollution coming from outside of the country. The second piece of information that is delivered are the physical health benefits. These include the avoided premature mortality, which can be categorized in terms of death counts and life years gained, and as well as morbidity. So we're looking at prevented incidences of illnesses in children and adults. These may include hospital visits, visits to the emergency room, asthmatic effects in children, loss of work days because people, there's work absenteeism, people can't go to work because they may have to go to the doctor. And finally, these physical health benefits are characterized in economic terms. And as I mentioned previously, this economic exercise takes into account both market and non-market variables. The market variables are easy to understand. Somebody doesn't go to work, and so there is a loss of daily wages. That loss in daily wages obviously has an effect on economic productivity, both for the producer of the item that we're talking about, as well as the ripple effects across the economy. And then there's the welfare gains. These are intangible goods that are not per se economic losses, but they're a revealing of the experience of the desires of society to enjoy clean air. And so this is more of an information for the policymaker, the decision maker, to communicate what society prefers, how much it's willing to pay in order to achieve an environmental good. So the information A, B, and C that you see here could then be used as in a post-analysis where you might want to inform a cost-benefit analysis or cost effectiveness analysis. You basically compare costs of the abatement versus the rewards that are achieved. In this case, we're looking at the rewards that are achieved from improvements in health. And then, of course, you could also use this information as a feedback in the planning of your national action plans. Perhaps you might want to make them more ambitious. In the graphic that I included here is I wanted to highlight for you the fact that when you do reduce the emissions in a particular country, not only are there benefits to the citizens of that country, which are indicated in blue, but there's also benefits to the citizens that live outside of the boundaries of the country. So I look at three particular examples. These are three countries in Europe. You have the Bosnia and Herzegovina on the left, Germany in the middle, and on the right, you have Luxembourg. And as you can see, one characteristic, it has to do with the size of the country. So if you look at the last two bars, you see that although Luxembourg has reduced its emissions by 1 kiloton of PM2.5 in this example, it only benefits 20%, whereas 80% of the benefit touches outside of its borders, touches the citizens outside of the border. And that's because Luxembourg is a tiny country, and most of the benefit is achieved by Germany and France that surround the country. On the other hand, if you look at Germany, most of the benefit is enjoyed by its own citizens, whereas only 20% of the benefit is enjoyed by the countries across most of Europe. This is the basic analysis that you can run with the model. Of course, if you have more data, then you can run a more advanced analysis. And so here in this slide, I show you 6 possible options of additional data that the user could provide to the tool in order to run a more advanced type of analysis. You might provide, for instance, population composition by age and gender that would allow the model to run life table analysis. You might provide mortality data specified by cause of illness. That means the model can now run other health risk assessments and provide you with a comparative analysis of different modeling. Previously, we were talking about the global burden of disease, but WHO also has its own set of functions that are based more on all-cause mortality. So you could run both and compare. You could replace the generic default data that is used in Carbon H, which is based on international databases with location-specific information. And finally, you might also look at trying to disaggregate the benefit by sector. So you might have an intervention in the electricity sector, and you want to know how much of a benefit you're getting from that versus the transport sector. So all of this is information that the model could use and provide you with additional insights into the decision-making process. So I'd like to now go to the second part of my presentation where I talk about three particular applications of the tool, just to give you a flavor, a sense of what kind of information you might get. So in the first example, what I did is I considered the situation of the European Union, where we use coal and natural gas as well as renewables. And the question is, what if I shifted 50% of the current electricity mix from coal to natural gas? And if I did that, what kind of benefit would I achieve? So in this particular slide, I just summarized the different life cycle emissions of the two different fuel chains. And on the bottom right, you see what are the offset emissions from switching from coal to natural gas. This is the information that you see here, the PM, the SO2, NOx, and ammonia, information that is provided to Carbon H, and then it uses that to calculate the benefits to health. Just to put the number into context, you see that we could save about 84,000 kilotons of greenhouse gases each and every year. That is equivalent to removing 35 million cars off of the roads. And given that in Europe we have approximately 250 million vehicles on the road, that would be equivalent, just with this one measure, in removing the equivalent of 15% of the cars that are on our streets. So here's one of the several tables that Carbon H provides you. It highlights each of the different countries, what are the benefits to children, adults, whether we're looking at bronchitis effects, asthma effects, all ages, both children and adults combined, whether we look at the mortality, number of deaths in years of life gained, and then the monetization of the ensemble of information. You can also calculate what share of the benefit is attributed to mortality and morbidity. So in this example, 83 to 93% of mortality, of the total benefit is attributed to mortality. That's approximately 5,520 averted deaths each and every year. And this is in 2030. And we can also separate the benefit, for instance, to the EU versus the rest of the WHO Euro region, which covers the entire area from Portugal all the way out to the Central Republics in Asia. And then you can calculate the benefit to the EU population or to any one of these countries. In this example, I highlight that approximately 90% of the benefit is EU population. And to put numbers into perspective, these numbers correspond to approximately 0.1% of GDP of the Euro region. So it's a significant benefit that it is achieved by just this one simple measurement. In addition, the model can also quantify the cost of saved carbon emissions, which in this case amounts to 0.05% of the GDP price. Of the GDP of the Euro area. In the second example, I just wanted to highlight an example of the nationally determined coefficients for the entire WHO Euro region, 53 countries. If these were implemented, what could be the benefits on health that we could achieve? And in the bottom here, you see what are the reductions in CO2 emissions. And then in the insert, you see that compared to 1990 levels, we could reduce 17% of all PM emissions, a quarter of all SO2 emissions, and another 1/8 of the NOx emissions. So this information is fed into Carbon H, which then gives you something like this. So I showed you a table, now I show you a graph. On the top, you see if only the U28 met its pledge. On the bottom, if all 53 countries met their pledges. In the dark green, you see the benefit to the country that emitted the pollutant. And on the light green, the benefit to the country from all its neighbors cooperating and working together. So as you can see, there is a significant benefit in cooperation as opposed to going it alone. The benefit varies between 50,000 premature deaths, about 40,000 or so of those occur within the European Union. And to put that number into perspective, that is approximately 10% of all mortality that is attributable to air pollution as of today. And that corresponds to an extension of about 14 days in life expectancy. If all countries work together, the 50,000 increases by 50%, it jumps to 74,000 premature deaths that could be avoided, and consequently you would gain approximately another week in life expectancy. Again, to put these numbers into context, you gain roughly a month if everybody cooperated, and roughly somewhere between 6 and 8 months is the loss of life expectancy in Europe. And then finally, you see the economic benefit, which ranges between 100 and 300 billion US dollars, and that represents between 0.5% to slightly over 1% of GDP of the entire WHO Euro region. And I'll conclude with something local to you, closer to Grenada, Colombia. In this particular slide, I was curious to see what would be the benefit in Colombia and its surrounding countries if I reduced the emissions of PM 2.5 by 10 kilotons. And what I highlight here is the reduction in postponed deaths. 90% of the benefit would fall onto Colombian citizens. And then most of the remaining 10% would involve Ecuador and Venezuela, with small shares of the other countries throughout South America. And then in the bars, you see the economic equivalent of this postponed mortality, of course, greatest for Colombia and decreasing as you move further away from Colombia itself. And the one final piece of information that the slide provides you at the bottom left is the marginal benefit, which essentially tells me that there is a 4.3%, $4.3 gain for every kilogram of PM 2.5 that is offset. This information is useful because you don't have to run the model every time. You run the model once, you can obtain marginal damage costs cost per kilogram of PM, cost per kilogram of SO2, cost per kilogram of NOx. And then that could be put in a lookup table. And then depending upon the different national action or regional action plans that are considered, you would simply multiply the marginal damage cost times the emission. And that would give you a first estimate of what is the economic benefit of that particular policy. Or you might simply re-express the results in terms of number of deaths that are avoided per kilogram, or the extension in lifetime expectancy per kilogram of a particular pollutant. So with that, I will stop, and I thank you very much for your attention. And if you have any questions, I'm here to answer those. Thank you.
Thank you very much, Daniel. Thank you very much, Jonathan. Thank you very much, Joseph. Very comprehensive. I believe our participants would have gained a better insight into how PARCO WHO actually operates and functions in terms of collaborating with its member states, its governments, and how they also partner with local organizations and even non-governmental groups as well. We also recognize that a lot of priority areas going forward, it's long-term, and a lot of strategies and initiatives are required in terms of addressing some of these critical areas as well. A question that came up I would like for us to comment on, and of course we're pressed for time in a bit, but I think it will be beneficial to receive your perspective. As a result of COVID-19, restrictions in travel, whether it's in automotive, whether it's in aircraft, and some of the modern sources of air pollution and contamination, that has been restricted and limited in response to COVID-19. Now, what do you expect? What do you project the period of this pandemic to look like in terms of the data, in terms of the health impacts as a result of potentially the reduction, hypothetically speaking, of these pollutants from these responses?
Who's the question for? All three of us, or?
Any and all.
Go ahead, Joe, since you got the mic.
The jury is still out as far as like how much of the COVID is going to have an impact. You know, what the link is between COVID and PM exposures. We will find out over the next year some preliminary estimates from GBD, who's working on this, to try to quantify the effect. The effect that generally are quantified by GBD has to do with long-term exposure. So the reduction in concentration levels, particularly of NOx, that we saw in Europe and China, that we see on the news, those would produce short-term effects, the reduction in the day-to-day mortality. But we're interested in long-term effects. That means long-term changes in pollution. Now, on the positive side, this is an opportunity to make a change. When we get back to business as usual, if we approach it from a sustainable perspective, from a perspective of utilizing clean energy sources, this is an opportunity that we should not let slip through our hands, because we have seen what we can do. We have seen that because of the pandemic, we have to do very drastic measures. But this is what the future should look like. Doing these measures, cleaner energy, electrified transport, et cetera, in order to reduce these particular emissions and concentrations. So this offers us an opportunity to rebuild, but rebuild sensibly from where we started. So that is really the benefit of the COVID experience. The other thing with linking PM with COVID, it was mentioned before that because particulates inflame the lungs, amongst other things, and COVID is basically an exacerbation of that inflammation, that it's clear that there is a link there. The question, though, that is not clear is it the dominant pathway of contribution of the disease? In other words, is there a carry and boost effect? The particles are latent with the virus, an active virus, and then this eventually goes and enters into your lungs, and therefore it delivers the extra dose, and therefore that causes the adverse health effect? Or is it the person-to-person, the community spread, that is most important? My thinking right now is that the community to the person-to-person or community is stronger than the effect of pollution itself. But we'll have to wait to see if it's 30-70, if it's 50-50. That will take time. In fact, we started here, I'm speaking to you from the Basque Country in Spain. We started a local study to see if we could isolate the effect of individual drivers to determine what the share is.
Thanks, Joe. Daniel?
Thank you, Satish. No, good question, and I'll expand the answer perhaps in a different direction. That also what COVID is teaching us is about the importance of having surveillance systems in place, and integrated surveillance systems even better, including health data, environmental data, production and consumption data, socioeconomic data, and that's crucial for us to be able to anticipate events, creating early warning systems, to have a communication system also in place with not only the decision makers, but also the large population. And to be able to with that in hand, and having the models also projecting some trends, to already get ahead of the game and build preparation, response, and early recovery measurements and measures. So we need to have the clear indicators to measure that, but also all these structures in place to be able to quickly respond when it's inevitable to have one of those events. Prevent whenever possible, but also having this scenario that is not everything is preventable entirely. So we need to have response mechanisms in place, and that are widespreadly communicated and built with multiple sectors and multiple institutions and the society at large. So I think that this is also something that COVID, unfortunately, is teaching us the hard way on the importance of really running ahead of the game instead of waiting just to react after things are triggered.